Welcome, everyone. I see folks are still trickling in, and so I'm going to give folks a few seconds. We do have a wonderful, robust discussion planned. All right, I still see folks. I'm going to give folks 10 seconds, and then welcome. Welcome, everyone. See our CDC colleagues joining. Yay! All right, and confirming everyone can see, I advanced my slide, right? Yes, awesome. Well, thank you everyone for joining the October prevention session of the Virtual Learning Collaborative, made possible in partnership with CDC's Division of Viral Hepatitis. My name is Isabel Lechuga. I use she/aya pronouns, and I am a senior manager here at NASTAD. Today's session is part one of building or enhancing a coalition to eliminate viral hepatitis. I am co-moderating the session along with Dr. Mona Doshani, medical epidemiologist with the clinical interventions team / program team at DVH.
Hi, everyone. Glad to be here.
Joining us today are Alena Pittman and Arlis Jenkins from the Arizona Department of Health Services and Thaddeus Pham from the Hawaii Department of Health. Just to give everyone a bit of an overview, the session format for today entails starting our session with a discussion between Mona and myself and our health department colleagues for about 30 minutes, followed by Q&A with the audience for the second half. So please feel free to use the chat box to introduce yourselves, the jurisdiction you're from, and ask questions throughout the session. To start us off, let's set the tone and get into a headspace that allows for us to focus and center on the abundance and strengths in the different contexts we are working in. Systems thinking is encouraged, including understanding context and intersectionality and seeing patterns, collaboration, specifically focusing on building a bigger pie. So here we're building a bigger pie. Mutual support and promotion of our work and issues, power sharing, including valuing and requesting ideas at all levels and making space for them to be heard. One of the most important takeaways is for us to have a clear understanding that to change everything, it takes everyone, and to name the need to work from a movement lens. Our intent is not to talk at you, but to facilitate a space to validate and allow for peer-to-peer exchange. Sessions are intentionally meant to follow the ECHO model and being discussion-based, but even though we are meeting virtually, this is still a space for us to build community. So I definitely need to start and begin with a shout out and gratitude to HepFree NYC and HepCap for asking questions that we'll be including in our session today. And what we aim to complement the September NVHR grassroots call that took place a few weeks ago. I also want to recognize and thank Alena, Arlis, and Thaddeus for the TA they provide with enthusiasm, considering they're always being pulled in many directions. We will begin our session with a bit of background. So Mona and I will popcorn questions to our colleagues, and we'll start in alphabetical order, beginning with Alena, then Arlis, followed by Thaddeus. So first, introductions, and if you can speak to us about your role with both the health department and coalition, and how long you've been in these roles. So, Alena.
Hi, so my name is Alena Pittman, and I am the epidemiologist here at ADHS in Arizona. I am a co-facilitator, and I've been in this position for about 2.5 months, so I'm still new, very excited to be here. Everyone is super nice and helpful. And right now I'm helping to facilitate the data subcommittee that is monthly, and it is partnered with our community partners here in Arizona.
All right, and I'll go next. My name is Arlis Jenkins. I'm the Viral Hepatitis Coordinator at Arizona Department of Health Services for our Hep C Elimination Planning Advisory Group called HepFree AZ. I'm a co-facilitator, organizer as well. I've been in my role at the Health Department for 2 years, and we've been working on Hep C elimination planning for 1 year.
Hi, everyone, and aloha. My name is Thaddeus Pham, he, him. I'm the Viral Hepatitis Prevention Coordinator at the Hawaii Department of Health and also co-director of our Hep Free Hawaii Coalition, which has been around as long as I've been a coordinator, which is 10 plus years now. And very excited to be here. So thanks.
So I'll start with one of the questions. So this question is a little bit lengthy, but I think it forms the basis of our presentation today. So could you describe your coalition structure, how it was formed, and what are some of the advantages and disadvantages of your structure? And while you're explaining that, can you also share some information on, the number of members, their roles, who do they represent? Is it, members more from the clinical setting, members more from law enforcement, or other agencies like insurance and others? And how do you really optionalize these subcommittees? Sorry, I have a little sore throat.
No worries. Yeah, I can go ahead and start that, and I'll hand it off to Alena for the second part. But Hep Free AZ is our statewide Hep C Elimination Planning Advisory Group. We turned 1 year old this month, actually, so it's great to reflect back on what has been a year full of learning, really starting conversations that were long overdue about hepatitis C in Arizona. In terms of our structure, we mirrored this off of our statewide HIV advisory group, which was formed in 2015. So we have an executive committee that holds 7 members, including an active chairperson. We have 3 subcommittees as well. Each has capacity for 7 members. The subcommittees are data, advocacy, and marketing. In terms of advantages and disadvantages, one of the disadvantages is that we're pretty formal. We have an official charter and bylaws. We have an application for full-time membership, conflict of interest form for our committee members. And the formality at times makes it difficult to engage new members since we're fairly structured, and nothing seems to scare people away more than the health department giving them a bunch of paperwork. So we're definitely learning from other groups such as Hep Free Hawaii, how to involve people in other ways that is more accommodating to the realities of their life and the type of work that we're embarking on. In addition, even though we've had a great example to look towards with our HIV advisory group, the structure did take some time to build up as well. So the first 3 months were dedicated to really forming the committees. It took another few months before our structure was truly finalized with the official charter and bylaws. But we have seen some advantages, including having clear directions and expectations of our members. And it's also very scalable. We're able to sort of build on the structure that we've put down, the initial foundation, in a way that allows us to work with a lot of stakeholders simultaneously in different areas within the different community committees. So each committee has its own autonomy. Another strength has been the ability to work on the implementation of special projects within the subcommittees, simultaneous to the development of our Hep C elimination plan. So instead of creating the plan first and then working on implementation, we're able to start projects now and really make some impacts within the community. And I'll go ahead and hand it off to Alena to talk about the numbers.
Hi, so right now our group has a total of about 70 full-time members, and this just means that all of them have completed our Hep Free Arizona application. We also have an info sheet that have led to more interactions with other groups and individuals, which will allow us to be more flexible, whether we meet with them one-on-one or if they join our group. So that's been really great. Our meetings are held on a monthly basis, and they're open for anyone to join, anyone at all. And they can also join within our subcommittees as long as we're not at that 7-person capacity. And then within each of our groups, we do have a very healthy mixture. Right now we have clinicians, we have nurses, other coordinators, research professors, public health workers, and community members. We also have an abundance of medical professionals such as doctors, PAs, NPs, and pharmacists. And in each of the groups, we try to have some harm reduction workers and people with lived experience. So that gives us a more well-rounded view in all of the groups. And then as Arlis had mentioned, we do have the 3 subcommittees, And we try, the executive committee is able to create ad hoc committees as needed, which is great. And the subcommittees also meet on a monthly basis just to touch base to see if anyone has any problems, if there's any solutions, or if anyone's making any headway in their projects. And we also try to incorporate people's stories and experiences to understand the data systems and working on advocacy initiatives as well.
Great.
That's great.
Yeah.
Thanks. And always inspiring to hear from our folks in Arizona, because we reached out to you so often for help with our coalition. So hi again, everyone. Thaddeus with Hep Free Hawaii and the Hawaii Department of Health. So our structure, which is a great, I think, in comparison to Arizona, is very loose. So we don't have as a formal structure. We do have a general steering committee, which includes the harm reduction folks, people with lived experience, myself as kind of the backbone organization with the Department of Health, and then our clinical providers. So it's about 8 people kind of representing those different roles, and also care coordinators. And we try to ensure that it's diverse, both in race, ethnicity, also gender identity, and also geographically. So we always try to have our neighbor islands represented as well, if possible. You could see here, so because we don't have as formal a structure, we do, one of the challenges, right, is that we have to re-educate people all the time in our coalition. So we remind them how we work. And at the beginning of every meeting, we restate our values, which helps orient everyone who's coming from these different places. And then we also restate how we work, because it is a little bit looser. So we always say, these are our 5 elimination priorities. And similar to what Arlis and Alena said, we use our priorities as our work groups or our subcommittees. So for us, that's awareness and education, access to services, advocacy at all levels, equity in everything we do, and data for decision making. And this came from a year-long process of engaging with, I think, over 120 different stakeholders across Hawaii, and actually some folks from the continent as well. So, so we restate this every time, and then we also restate that our goal and objective is grounded in these, but it's not limited to these in a way. So we have what I think Arlis kind of references, but we really rely on micro elimination opportunities. So really acknowledging that our community members and our stakeholders know the best what are the opportunities that are local, and we pursue those opportunities, and we try to support them and to also document them. So at our last monthly meeting yesterday, we highlighted 20 different microelimination projects, so about 4 in each one, and all of them are currently ongoing. And you can imagine how messy that is, like spinning plates, you know, multiple plates. But for us, that works, I think, because we don't have as strong of a backbone in terms of support. So it helps to have multiple kind of things going all under one kind of umbrella where we can all check in. So since it's kind of a little bit looser, we don't have any formal entry or pathway for folks to join us, so anyone can join us. We try to always also reiterate low threshold engagement. So I just scanned right now. So we have about 160 people who at least have shared their email specifically for hepatitis elimination. As you can imagine, doing any coalition work, it's like 160 people. So that's probably like 30 people who actually will be actively involved. And I just checked our notes from yesterday. So it's actually about 30 people who attended. As part of our low threshold engagement, we also have monthly meetings for the larger group. And we hold 2 meetings, one at noon and one at 5, because the feedback was that some people couldn't make either one. So we create multiple meetings to address the needs of our different folks who might be working, or people with lived experience who have to make money during the day. We also have monthly meetings for each of these work groups, similar to what Arlis and Alena were saying, to kind of address them and focus on those priority areas. In each group, we have about 20 people signed up. And again, that translates to about maybe 3 or 4 people who are actively doing and actively pursuing it, which is pretty exciting for us in terms of engagement, because it's always hard to engage so many people. Mona, to speak to the diversity of stakeholders that we have. So we do have many folks with lived experience and from the community, which is what we're most proud of. And I think that is one of our notable successes, is because we created this low threshold, a little bit less structured way of engaging with folks. I think it's welcomed other voices in that that we're hoping to include. But we also have clinical folks, we have harm reductionists, of course. We don't have law enforcement, but we do work with public safety a lot. So even though they're not formally engaged, for example, I mentioned to Arlis and Elena, we're working with them on 340B pricing. Our Office of Narcotics Enforcement Division is involved to submit bills for us. So there's a lot of those other relationships that are not as formal, but that are equally as important. I tend to talk a lot and voluminously, so I'm going to stop there, but I hope that gives a little bit of a snapshot in terms of our structure and what we do. Thanks.
Yeah, just like your eyelashes, right, Thaddeus?
Yes, thanks for noticing, Isabel.
You're welcome. Okay, so then actually both of, or everyone mentioned Arizona as the coalition or the health department being the backbone organization. So to kind of clarify it a little bit more, it's responsible then, meaning for maintaining engagement and executing activities.
Yeah, I could take that one. So in Arizona, ADHS is very much the backbone organization in that after a series of listening sessions, and we saw there was interest in Hep C elimination planning, we took on the role of the initial facilitation of these meetings and sort of bringing people together. And that has continued on. We do have some community co-facilitators as well, but we do a lot of the coordination when it comes to the actual Hep C elimination plan that's being developed within our executive committee. We do a lot of work to help sort of compile all of the information, make it readily available for them to quickly sort of make decisions and progress on the development of the plan. But yeah, I would say that we lean very heavily upon our partner organizations for aspects that we're not best suited to address, which can range from advocacy work to even just social media and things that we don't do as well as some of our other partners. I think the list goes on. On average, we ask our official members to commit around 20 hours per quarter to our Hep C work.
Okay. Thaddeus, do you want?
Yeah, everything Arlis said, and
Okay.
and
Yes.
also note, and I think actually Arlis shared with us some of their stuff, and so they're really good at documenting, and I think that's important for us as health departments as well, is to show the work is happening. So we do similar to what they do, and then we found that having meeting notes and having attendance sheets is really helpful for our legislators and our upper leadership to show that things are moving and that we're engaging with people. So even though we might, like, we don't have a surveillance, a great surveillance infrastructure in Hawaii for hepatitis, but it's enough to move things forward. So I think that backbone documentation is really important for any health departments who are involved in coalition work to show some sort of movement. I don't know if Elena or Arlis, you found that too, but that's just what we found locally.
Yeah, completely agree real quick. I think the consistency of it seems to be very helpful in that, you know, there's a set pattern, we do a monthly meeting, the documentation is sent out. So I completely agree that while tedious, it does seem to be very advantageous as well.
Okay. Yeah, I'm hearing it helps with sustainability. It helps with accountability. Okay. Love it. Here for it. Now let's talk money. So can you describe how your coalition is funded? Who applies for funding? How said funds are used and dispersed?
Absolutely. So in Arizona, funding is definitely a challenge for our group. It is not a designated nonprofit or an official entity. This is really just the health department gathering with community partners to be productive on Hep C strategies and implementation. But we have found success in a couple of ways. The first would be through the CDC PS 21-2103 funding component 2, We are planning on partnering with a local CBO to conduct outreach work to really help bring in some of the key individuals we need, with persons with lived experience, just general community members, people that maybe wouldn't be as responsive to these requests coming from us at the health department. So we're excited to begin that work. And I think that's another way that we can help ensure people are compensated for their time as well. Although things are very slow moving, so we're still waiting on some items to go through before that's official. The second area we've had success is to really look towards the integrated planning efforts we just started with our HIV team and our STD team. This has brought on additional resources. We just started, we're a couple months in. We're working on a needs assessment, some other key projects as well, focus groups down the pipeline. And we're very excited to be able to compensate individuals for their participation in the creation of the needs assessment or within the focus group through this collaboration with our HIV and STD programs. Aside from that, I think we're always looking for other ways, and I know some of our community partners are brainstorming as well on possibilities to help ensure that we can have some funding.
And I'll add for Hawaii, yeah, funding. So it's specifically for like elimination planning and implementation that we don't really get dedicated funding other than from the CDC to support the position for the viral hepatitis prevention coordinator. However, we do a lot of support for our community partners to build up their funding sources. So for example, we will help them write grants that they can submit to, so it doesn't have to come through the state bureaucracy. Our coalition is fiscally sponsored by a nonprofit, which is our statewide syringe exchange. So as part of that agreement, the coalition gives the syringe exchange about 10% of incoming funds so that they can provide a lot of that infrastructure support, like accounting and all those kind of things, like getting checks out to people, all those things, so we don't have to do it and we don't have to go through all those levels of bureaucracy internally. SIBA was really helpful. So we partnered with our HRV folks to reach out to the capacity building assistance folks for HIV. And that's how we got the wonderful Katie Burke from San Francisco to kind of help us start our stuff also. So that was a great opportunity. I think maybe as viral hepatitis prevention coordinators, we're just used to figuring out how to make things work. And then also I'll just note that I saw Rachel's comment in the chat about longevity and sustainability, and this ties with funding too, is that one of our core values in our coalition is social justice and intersectionality, which allows us to broaden our discussions when we talk about hepatitis elimination to include things like, anti-racism, housing, LGBTQ equity, all these broader issues, which allows more people to kind of work with us and also allows them to share resources more too. So I think those intersectional discussions are not only important and essential, but powerful for our work in hepatitis to expand the breadth of what we do, including funding and including relationships and longevity. So that's all I have to say about that.
Yeah, and the next question I have here, I think you already touched on it a little bit about in terms of leveraging resources. I know y'all mainly talked about federal and other partnering with other health departments like HIV and other programs, but could you speak a little bit about how you've used it in terms of the clinical champions that you have a relationship, how you have utilized them in terms of building that relationship and leveraging that resource that you have?
Okay, yeah. So the people that we have used here at ADHS, we have used Southwest Recovery Alliance, and it used to be Chris Abert, and he took a leave. So now we have Missy, who is just fantastic. And we also are in partnership with Global Liver Institute, and Gina is the head of that, and she's also just absolutely phenomenal. So honestly, having those two have just been invaluable to us, whether it's networking with other places or just trying to get us in touch with the person that we can leverage to talk to, hey, we need a partnership because of this and this, how can we help each other? So those two have just been absolutely fantastic. They also help with co-facilitating our monthly meetings so that we can sort of take a step back and just watch them do that. And then they also provide just a lot of other support in different areas. And we have also been able to expand our reach because of them, because whether it's with Gina or Missy or Chris, they know people that obviously we don't know. So it's nice to be like, oh, hey, you want to do this? I think I know someone that works at Valleywise or at Mayo. Or so honestly, just having that network of people that will put us in contact with other people have just been absolutely invaluable. And also the other thing that helped us was the guidance documents that the CDC had released was also just absolutely phenomenal as well.
Thank you.
Yeah, that's a great question, and always inspiring to hear what folks are doing in Arizona. I'll just note on top of what Alena said, we also found that the ECHO project, so we just had our first ECHO. I know a lot of folks are already doing it, but we had our first ECHO project this past year for hepatitis C, and it was a 16-week kind of module. And that was a really great way of meeting with providers, clinical providers, and champions over an extended period of time, and having them get to know us, get to know the work, so that in addition to the clinical case study and the didactic, we also integrated a piece around advocacy at each point. As a health department person, I'm not an advocate, so I was educating them, but we had our community members saying like, you know, as you could be, your voice matters, and they would try to integrate them into the advocacy piece of the work. Something else that we found useful is we were able to give out small mini grants to some of our FQHCs or community health centers. And as part of the MOU or the contract with them, we required a clinical champion to be part of our coalition. So we said, you know, you'll provide this, you'll do testing or whatever, just small things, and you will attend the monthly HEP coalition meeting. So that was an easier way to kind of get them involved. And then over time, I think that allowed us to build relationship with them. Finally, something that was helpful too is to see if any of our clinical providers are the leads in any of our chapters of like physician or pharmacy coalitions also, so we could fold in other coalitions. So for example, one of our providers last night mentioned that he would be willing to leverage the power of our local chapter of the Academy of Family Physicians if there is any need to do legislative work in the future. So kind of seeing who's place in those spots is helpful as well.
Oh, that's actually really exciting. And I will say, Thaddeus, you, I think, coined the term, we're rich in relationship capital. So I appreciate that. This is kind of segueing then into how does advocacy work considering the limitations of the health department? And you both have started speaking to partners, so any partners you'd like to acknowledge and really like how you're managing that, if you can speak to it.
Yeah, definitely. In Arizona, at the health department here, we do have limitations when it comes to advocacy work. We cannot lobby. So we are completely separate from these activities and are therefore very thankful for the partners we have who assist with these types of initiatives. And this primarily takes place within our advocacy subcommittee. Of course, there's work happening, externally within the community. That's been a great asset as well, considering the landscape of Hep C in Arizona. But we work with the aforementioned Southwest Recovery Alliance, Sonora Prevention Works. Really want to acknowledge Chris Abert, Missy Downer, and Haley Coles for really doing the work and digging in years and years. It's been of really being productive in an area where, again, our team is more limited. When it comes to harm reduction work as well, there's some local HIV CBOs that are very helpful as well, and that we collaborate with, including Aunt Rita's Foundation. So it's a team effort to really make progress in this area, and we're, again, so thankful for these key partnerships.
Yeah, and to echo what Arlis said, we have limitations in Hawaii too around lobbying and the role of advocacy. So we always just restate that we're just providing education in our roles from the health department. And I have clarified this with our Attorney General that we can also show the implications of a decision, although we're not lobbying for it. So we can say, the impact of this would result in this, which is kosher, I think for Hawaii at least. But yeah, like Arlis said, it's separate from us. So we rely on our community partners to kind of do the advocacy work. Something that we also try to do is with, because we do focus a lot on community and storytelling, we just try to build up and empower our storytellers so that they have a voice with which they can do whatever they want with, right? And hopefully that's for the benefit of public health. And that includes not only locally, but increasingly the voices of our storytellers are used nationally or promoted nationally in conferences and stuff too. So I think that building up of community voices is really important for this work as well.
Thank you. That's just great. Can you speak to a little bit about specific achievements or events that created substantial momentum for your coalition?
Of course, yeah. 2021 actually treated Arizona pretty good. So, for instance, in May of 2021, the governor had a proclamation for Hepatitis Awareness Day. So that was fantastic. And then as of this month in October, SSPs are finally legalized statewide in Arizona. They are on a local level, but yeah, I know, I'm like, woo, and fentanyl strips are also legalized as of this month. And then the last one would be the sobriety requirements have finally been removed from our state Medicare's prior authorization requirements for Hep C. So 2021 has been treating us pretty good. I feel like that has definitely helped the momentum. So if we can just keep it going, but honestly, just getting a lot of backing from community partners and other government entities has just been fantastic for us this year.
Congrats to Arizona, first of all. That's amazing. I think some of the stuff for us, I mentioned ECHO, which is really important for us. So now actually it's become, we have like kind of a harm reduction ECHO hub, and our current one is on medication for opioid use disorder and the integration of hepatitis into that. So that's been really exciting. We're also working with our Hawaii Opioid Initiative. So kind of really, again, reminding folks about the intersection of hepatitis and substance use disorder. So we're funding care coordination in different sites for care coordination that looks at both medication for opioid use disorder and hepatitis C, and using each one as an entry point to discuss the other. And that's at SSPs, at FQHCs, at syringe exchanges, and at methadone centers. We did have a success this year in terms of legislatively. So the legislature passed a resolution that recognized hepatitis elimination as a priority for the state. And so we have an informational briefing next month, which I have to write the agenda for now, but to really inform legislators why hepatitis elimination is important and why the impact goes beyond hepatitis, right? And then finally, I mentioned this already, but thanks again to NASTAD and thanks again to Arizona. But thanks to both of you all, we're able to kind of start moving on 340B pricing for our public safety division so that they could do more Hep C treatment. So yay, partners. So that's some of the exciting stuff that's happening.
Yay! Oh, I feel like a proud mom. Okay, so then let's discuss, if we can speak candidly, bringing our humanity here, what is the best part of your job, specifically with the coalition?
So my favorite part of the job in the 2.5 months that I've been here, I think honestly would be the community partners. And the fact is that we are connected to so many people, whether it's Hawaii or just other parts of the US. And being here, I realized one of my favorite quotes was, you don't have to reinvent the wheel, right? You just got to like modify it a bit. So seeing what other people are doing and how it's working for them. And maybe that exact formula won't work for Arizona, but maybe we can tweak it a little bit and it would work. So I think in my experience, that's my favorite part. Be like, oh, wow, I didn't think of that. We could try that and it might actually work. So I think for me, that would be my favorite part of the job so far.
Absolutely. And I'll just echo Elena, 100%. It's the people, it's great to have everybody get together and connect in a way that you kind of felt isolated before. Working on hepatitis C can feel at times isolating. And then the second part of what you said, Elena, we get to be very creative when working on hepatitis C. It's almost a necessity, but it's great to work as a team and come up with these creative solutions.
Yeah, I feel like I just copy whatever Elena and Arlis said. So everything, all of that. And and also I think just like it was really moving because our coalition is values driven, and every time we start a meeting we say our 4 values again, which I'll just say it real quick, is harm reduction, intersectionality, social justice, and aloha. And it's really just and because of that we're very community centered, just like you folks. So it's so amazing when someone with lived experience comes up and tells us that this work is important and that they feel valued and heard. That totally makes up for all the other challenges that we have. So I think that's the most beautiful part for me.
So with that being said, with all good, there's always also not so good that follows through. So can you speak a little bit about your most unfortunate part of this job, mainly the coalition?
Yes, I'll take that one. And I feel the elephant in the room is that there's a lot of work that goes into creating even just the elimination planning group, let alone the development of the plan. It demands a lot of our health department staff, since we are the backbone of this group. And when I started, it was just me, but we've been very appreciative and thankful to have built our team up. And a lot of that has been due to the CDC Public Health Associate Program. We had our first associate start last year. Shout out to Jess if she's watching. And then Elena, as she mentioned, is new to our team as of 2 months ago. And as of yesterday, we actually welcomed 2 more CDC Public Health Associates that we will be training and incorporating into our work. And so that has really been helpful since there is a lot of demand for the analysis of all the discussion data, the coordination, and really the consistency to keep the group moving forward. So I would say that that's one of the biggest challenges, but I think the pros outweigh the cons.
Yeah, I think the challenging part is like all that work. And I think it's also the soft work. It's like Isabel said, we're rich in relationship capital, but it takes a lot of time and investment to cultivate relationships and to maintain them. And I think this is a part of hepatitis and maybe public health in general, is like that we don't always think is like a focus, but is so necessary for all the work we do, is all that time that's required to do really intentional relationship building, and also how we can demonstrate that to funders or to legislators to show like this is part of the work. And so that's always a balance, is like doing the stuff that you can show, but also doing the stuff that's really important to keep it going.
I appreciate that. I did see, it looks like Jess is on and said thank you, which is very, very lovely and validating. Okay, now I want to pause and see if, because we did mention we want to protect time for discussion. Questions, I believe I did see a question from Rachel, but Thaddeus did speak to it. So I'm gonna just pause. Maybe if we can get into a little bit more of the longevity sustainability, especially from Arlis and Elena. Do you envision these groups going on for 5 years, 10 years, 15 years?
Yeah, that's a great question. And yes, we do envision this group going on in the future. That's partially why we took our time really developing it and why we have such a more formal structure. We've looked towards, again, our HIV statewide advisory group has been going strong for 6 years. The work they do changes over time. They go through their own planning process, at times repeats, and then they have other projects they work on. But that's sort of what we envision for our group as well. Our biggest goal right now is the development of a Hep C elimination plan. After that, we plan to work with the group on implementation and other initiatives as well as they arise. The group is really to serve as a liaison between the community and the health department staff, not just here at the state, but also local, so that we're getting information and having conversations to make sure that when we have resources, we can allocate them to the best of our ability.
I'll also just add to that also something that we found helpful in terms of sustainability and longevity is to be responsive to our community needs. So for example, I mentioned that we have multiple monthly meetings, even though it's the same meeting, to accommodate different schedules. We've also changed our documentation and presentational style meetings to respond to folks. So for example, yesterday we just started doing a new way of showing the different micro-elimination projects that's more visually engaging so that folks can participate and engage with it more. So kind of being responsive to the community needs has been very helpful for us.
Thank you, I appreciate that. Okay, so I have a question. It looks like from Tara. Can you talk about the Hep C echoes in your state? What is your participation like? We have very little participation in HCV echoes here in Missouri.
Yeah, in Arizona, we have one hepatitis C echo that we're aware of currently that does a lot of great work connecting rural providers to specialists so that they can fulfill some of the prior authorization requirements that are in place for patients to receive Hep C treatment. And this has been in place for quite some time. It's something we're hoping will expand and reach more providers. I think they've seen some growth take place over time, but we know that the state is quite large and there's a lot of room, hopefully, for this program to continue to grow.
Sorry, yeah, I was just looking up our numbers for our Hep C echo. So our Hep C echo, we had 40 unique participants over 16 clinics for 16 weeks. And so what worked for us, and each state is different, but what worked for us is we made it a closed cohort. So it was like an invitation. We were really focusing on FQHCs. And then we also included the entire care team. So we really tried to get CEs for pharmacists. And then we are trying to see if there's opportunities to get kind of CSAC, which is for our substance abuse counselors, credits, and also social work credits as part of it, so that the entire care team could join. So it wasn't just the providers, but we had a lot of strong pharmacy folks involved who gave a lot of insight on prior auths and all the kind of medical management that they've done for hepatitis C. So that was really helpful. And I think that closed cohort for us made it a safe space so that newer providers could feel like they could ask questions and present.
Thank you. Okay, we have what I see our first raised hand. Amelia, you have the option to mute yourself, right?
Yeah, can you hear me okay?
Yes, welcome.
Yeah, thanks. It's easier, I think, to talk sometimes than type. So in Utah, we're just starting our elimination planning, and I feel like I'm drinking from a fire hose. So I have reached out to a bunch of stakeholders that we identified, but I guess I'm curious. I mean, I heard in Arizona, you guys didn't necessarily have a draft elimination plan in place first. I'm curious, maybe not even just from you guys, Arizona and Hawaii, if others have input as well, what you've had in place prior to bringing that group together. I've been working on a draft plan just to have something on paper to share with the group and try to get feedback. But I guess I'm just curious, like somewhat of like what steps did you take to get this going and make sure I'm not missing anything? I understand everybody's a little bit different too, but yeah, thanks.
Definitely. Well, congratulations on starting, and that feeling does seem very familiar. I can think back to feeling that same way. I would say our initial steps, and now there's more guidance available, so I definitely would look at CDC, viral hepatitis, strategies and the HHS strategic plan and the guidance that's available. But in addition to that, we reached out to different groups that had already published their plan. And I think in the beginning, we reached out to San Diego and Hawaii, which I think are great because they are very contrasting in some ways, gave us a good initial starting point of the different dynamics and things that we hadn't yet thought of to maybe start looking towards. I know Indiana as well has been really great. Some of our members, there's a lot of people from Indiana and Arizona, which is great because they bring a lot of knowledge and expertise. And so that was another plan we looked closely at. But we did spend quite some time kind of looking to see what was out there, having conversations with what was initially a smaller group. The co-facilitators we mentioned were the ones that were initially involved with this. So we worked with 2 organizations and kind of just had these calls initially before we opened it up to the larger group that we now hold every month with our meetings and things like that. So yeah, I would say a lot of investigation and sort of contemplation about what might work for your area would be helpful.
And Amelia, I'm just looking at our slide deck from our first planning meeting. And so what worked for us is we looked at other plans like Arlis was saying, and we highlighted pieces that we liked from each plan. So we looked at Baltimore's and Washington State's, and we're like, okay, we like this because it's more visual. We're not so into like that it's 79 pages, like things like that. And then what we did is we framed it as a series of questions. So we're reaching out to you as experts in your area, as persons with lived experience or as clinical providers, and we need your help. And these are the questions we have. And so some of the questions that we propose to them are, should we focus on B and C? What are some of the priority areas, which became a longer discussion over time? How should we meet? When should we meet? So we kind of framed it as like, we need your help. And then it allowed us to kind of build relationship and start engaging with them. And like Arlis said, it was a smaller group at first, and then we expanded it more and more as we had more to share.
I will say
You guys,
this.
go ahead.
Oh, no. Did you just want to say thank you?
Yeah.
Yeah. Yes, I agree. And also congrats, Utah. Also, Amelia is amazing and is our HepTech consultant. That being said, I think Thaddeus, what really resonated with me is the intentionality to weigh the storytelling. So what academia teaches us is qualitative data, giving it the weight it deserves and really centering it, because we go through school and it's all quantitative data, right? But the intentionality and y'all saying, no, what we need to make sure is communicated and centered is the storytelling. And so I really also appreciate that. And I think it's fair. I think it's fair to say that and validate it.
And I think one more thing that I'd like to mention that we had in our internal discussions was the availability of getting on one of the conference calls and learning from a jurisdiction. I think that is extremely valuable. And I know Arlis and Thaddeus had spoken about how they had helped each other during this process as well. So I could speak a little bit more about how that really was helpful. I think would be helpful too.
Yeah, absolutely. I can start. Yeah, we had a shared contact, somebody that knew Thaddeus really well and was happy to connect us. So we jumped on a call with the 2 other partner organizations, and Thaddeus was kind enough to just sort of walk us through all the things they're doing, going back because they were in their implementation phase already, but going back to the origin story for their group, so to speak. And we got a lot out of it. We took tons of notes. We met separately after as well to sort of just digest everything. And as Thaddeus said, you start to ask questions about how will this fit into the work we're doing? Is this something we want to prioritize as well? We had some really key discussion around that. And since then, it still continued. We are very thankful, Thaddeus, for that you help us within our marketing subcommittee. We're looking to begin collecting stories from community members to really highlight their personal experience. And that's something that is taking time to build up, but the information we are receiving is really helpful to make sure we're handling it in a way that is appropriate and that will work well. And not just jumping into something that might be overwhelming or not a good fit for our group. So yeah, I would say it's still ongoing, the back and forth assistance that we greatly appreciate.
Yeah, I agree. Like I mentioned, we reached out to Arlis in Arizona multiple times. So I think it's really helpful. And, you know, everyone who's doing HEP elimination work, because our community of HEP folks in public health is so small, has been really gracious with their time in terms of answering questions. So we also reached out to Washington State to kind of get some insights. We reached out to Baltimore, actually the Maryland State folks, to kind of get an idea of what the challenges were, what they would have done differently, things like that. So they were always really helpful. So I would just encourage folks who are starting to reach out to other folks who've done it, because I think they're your greatest resource for planning right now.
And I also wonder whether it would be a good idea to have like a repository. Like I know someone mentioned on this chat that could you share, and Thaddeus said, yes, email me and I can share some of our resources or tools that we have developed. I think it would be really helpful if others jurisdictions had some tools that they have developed or some templates which they think would be useful or helpful for others who are starting off or are midway through the process. I think that would really, would be really, really important and helpful.
All right. We have some guiding principles that we prepared, which are really words, wisdom, that I believe is wonderful from Alena, Arlis, and Thaddeus that we should get to. And I have it up here. I am looking at so we have about 9 minutes left, but keep the questions coming. If we can get started then with the guiding principles, that would be lovely.
We'll go ahead and go. Forgot the order here. So, and I think ours are the bottom three. So really the things that have emerged from us, leaning on our peers from other jurisdictions. I think the conversation we just had really spoke to that. That was and is one of the most valuable parts of what we do. It's great to be able to receive some of that expert knowledge from groups that have gone through this exact process. And even though it might look different, it's been really invaluable. I would also add to that, of course, NASTAD, as though a lot of great technical assistance and availability, which we've greatly appreciated. Another guiding principle, identify and be strategic about leveraging champions. Before we started our official Hep C elimination planning, I was just new to the job, trying to meet people in the community and scheduling meetings in person. This was pre-COVID, which was nice. And over time, some names kept coming up. You know, certain people would say, oh, you have to talk to so-and-so. And so following through on that was really helpful. And we're very thankful that a lot of those individuals are participating on our group in a way that allows it to be very respected in the community and for us to back.
Hello.
So, okay, I thought I was on mute this whole time.
How are you?
I think somebody.
Actually, I was. I'm just finishing up listening in on a meeting. Could I call you back at 4:00? Would that be okay?
Okay. We'll figure out who's on.
It's Ann Mormon.
Okay, I know. I was like, wait.
And that ties into another lesson learned, which is really adaptability. And I think just the fact that we're doing all of this teleworking and on Zoom and different conferencing platforms, has been extremely a wild ride, but interesting and valuable as well to the experience, and that we can bring that adaptability to our future work. The last one is really not reinventing the wheel, as Alena said. And this is something that we're so thankful for. We were able to really look towards our HIV program. Our office at ADHS is integrated. And so our supervisor works on HIV care and service. We have HIV surveillance. We were able to leverage some of their community connections with infectious disease providers and advocacy groups. With STD, which is also within our office, we were able to utilize some of their connections with tribal jurisdictions. And then I think Thaddeus mentioned earlier as well, other existing coalitions and groups, Project ECHO, which in our state is facilitated by a private entity, but it's a great collaboration to have them on board. And then Strengthening Systems of Care is a separate HRSA SPINS grant that is involving people living with HIV and people who use drugs. So there's been a lot of close other groups that work really closely that have thankfully participated in our Hep C elimination planning work as well.
And I'll go over the top three. I think those were from us. So yeah, so our guiding principles for us, as you probably have already guessed, in Hawaii at least, is to center health equity and center people with lived experience. That was really important to us, and that came through just intentional discussions with people over that 1 year of planning that I had mentioned. And as part of that, formally within our document, it states some of the communities that are affected, and it states our dedication and our values again, so that we can always refer back to that as a reason for why we're centering health equity and the people with lived experience. So that was a powerful kind of tool to kind of formalize it within the document. Quantitative versus qualitative data. This is always something that is a thing that we're trying to do. Someone once told me that you don't get mad, get data, and I think that includes qualitative data as well. So especially in the cultural context of Hawaii and Native Hawaiian people and Pacific Islander people, the cultural component of qualitative data is really important to kind of highlight and uplift for us. So we're trying to figure out more and more how we can do that. And the last one is really just a reminder for all of us who are doing the work to give ourselves some slack, because we're presenting this now and it seems like, wow, we've done it, but the work is ongoing. It's messy. It takes time, like I said, and it takes investment and takes social capital. And we started our coalition 10 years ago in Hawaii. So it's taken us 10 years to get to this point. So give yourself that leeway and just take the time to plan, but also be flexible and responsive to the community needs. So yeah, so that's kind of some of our lessons learned.
I love that. That's beautiful. It's also, I'm also hearing, allow yourselves grace, maybe expect a lot of no's, but also allow coalition to be flexible members to come in and out, right? Because that's like basically adulting. So I very much appreciate that. That being said, we did pop into the chat box, wherever it is, the evaluation link. If y'all could fill it out for us, please, please, please. I think it's only either 4 or 5 questions. It's super quick to fill out. It's we use that data to inform the session. And we still have 3 minutes left, 2 minutes left. Y'all have questions. I have a million questions. But this is, okay, I'm gonna have one last question for all 3 of you. And you can speak to it as yourselves, how you're measuring success.
Yeah, definitely. Great question. And I think to speak to what Thaddeus said, yes, we do look at numbers. We're looking at our membership total, meeting representation and things like that. But it's also the quality of the interactions. And sometimes it's the smallest things that are really huge victories for us. We recently had one of the coordinators in the northern part of the state reach out to somebody in the southern part of the state asking where they can link somebody to care. And getting a response, which is great. So little things like that make a huge difference in the life of the client or the individual, and we consider to be very much a success.
Ditto. Everything Arlis said. Beautiful. I don't have anything else to add.
I know Thaddeus said I asked you what you would tell your baby self. 10 years ago from now? Now I'm gonna put you on the spot.
I would tell well, take time because it's going to take 10 years, baby Thaddeus. Moisturize, I guess, and be patient and invest in people. I think that's the most important thing, actually. Like, remember that the people are the reasons why we're doing the work.
I love that. And I think the legendary Katie Burke also said, like, to remember, we're working with people and people's lives. Don't forget. So that being said, evaluation link survey, please fill it out for us. And again, thank you so much, everyone, Mona, Elena, Arlis, Thaddeus. We really appreciate how freely, how gracefully, patiently you share your TA and your wisdom with us, with your colleagues. It's a privilege for us. So thank you.
I'm going to ditto everything what you said. It's awesome. Thank you.
It is. It is.
You all are awesome.
All right. Well, thank you and goodbye.
Bye. Thank you.
Thank
Bye.
you. Take care. Bye.